Hello, everyone, and welcome to Heads Up, the weekly webcast and podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel, migraine strategist, founder of the Facebook group Migraine Nation, and chronic daily migraine survivor. I am here today with someone we all know and love. This is Dr. Vincent Martin. He is the director of the Headache and Facial Pain Center at the University of Cincinnati, and he is the president of the National Headache Foundation. Hi, Dr. Martin. How are you doing today?
Good, Lindsay. I'm doing great.
All right. So today we are here to talk about accessing treatments during COVID-19, giving everyone some new and fresh ideas in case you're having trouble accessing the treatments you need, in case you're feeling sicker at home because of some of the problems we're having talking to and getting to our doctors at this time. Dr. Martin is doing telehealth visits with his patients, etc., and he has so many great ideas. So we're going to pick his brain today. So let's start out. There's so many of us. I think one of the first things I have seen a lot of and heard people talking about is that so many of us use Botox for our migraine. So many of us need it every 3 months. And a lot of us are not able to get it now. So I would love to hear about what you talk to your patients about who may be missing their next Botox treatment and not feeling so well.
Well, before I answer that question, I probably should preface it with the fact that not all doctors have stopped doing Botox.
Right.
So there are still some practices in this country that are doing it, but many healthcare systems like my own are prohibiting us from doing Botox because they think it's a risk to the patient coming into a facility where some patients could be infected with the COVID-19 virus. But it's also at risk to the health staff as well, to our staff. So at our institution, at least currently, unless there's extreme situations, you cannot get Botox. And that's a real issue because many patients, well, even as they get towards the tail end of their Botox, and even if they're not missing their Botox, they'll start getting this spike of headaches up and down and so forth. And oftentimes that will continue on for weeks until their next treatment. So skipping Botox is a big deal for many people that have been well controlled on Botox therapy. So you might ask, well, what do we do?
Right.
And usually what we have to do is consider either increasing other preventatives that might be effective. So a common one would be something called topiramate, or the trade name is Topamax. We might just bump up the dose of that. We might also consider starting other therapies. We could either add another oral medication, or another thing I've been doing more commonly is using what are called the MABs, the monoclonal antibodies. Those are shots. They came out about 2 years ago. For the most part, they're given once a month, although one of the three, called Ajovy, can be given every 3 months. And sometimes we'll give those as kind of a bridge therapy to get them to their next Botox appointment. The problem is we don't even know when that's going to be.
Right.
If everything gets bad here, this could go on for a few months. So I think you need to provide some sort of preventive therapies that might help. Now, along the same line, maximizing abortive therapies, I think, is important. So, there's a bunch of new abortive therapies that came out in the last 2 or 3 months. They block the CGRP receptor, which is similar to at least one of the monoclonal antibodies, and they're given as acute therapy. So you take them when you get the headache.
Right.
And sometimes you can give those in addition to their existing abortives to give them some additional medications they can use if their headaches do increase. And then the third thing I would say, besides maximizing their preventative, maximizing their abortive meds, would be to consider devices. There are a bunch of devices that have been shown to be both effective as abortive meds, or meds that treat the acute migraine attack, and preventative meds, preventative therapies, not medications, that actually prevent migraine attacks. And there's a few of them. There's one patch that came out recently called Nerivio that you put on your arm, hooks up to your cell phone, provides an electrical current to the arm, and actually decreases the pain of an acute migraine attack. So it's used just when you have a migraine. There's another one called Cephaly, where you put this little device on your forehead, and that can be used both to treat the acute attacks when they occur, and also it can be used to prevent. And there's a third one called GammaCore, which is a vagal nerve stimulator that's was just recently approved as a preventative, and it's been approved for a long time as an abortive therapy. And the nice thing about these devices is they can be delivered directly to your house, which during a pandemic is really important. You don't even have to go anywhere; that they can be delivered. They're still working on insurance access to those meds. Sometimes they can be a bit pricey. But some of them are quite affordable for many people. So I think there's a number of different things that one can do to maximize therapy during this pandemic.
Yes. And I think we should note too that if you speak to your insurance company and your pharmacy, many of your medications can also be delivered to your home, not just the devices. So that is something that if some people are having trouble or are not supposed to leave their home, or if you're immunocompromised, that's something you can look into. So let's move on to people who may go into status migrainosis, meaning they get one of their worst migraines. It lasts 72 hours or more. There are some things that people who might be used to this problem do, for example, going into a infusion clinic, etc., at normal times, and maybe what they use to treat themselves in this instance is not available to them with the COVID-19 restrictions. So let's just address that population and anyone, in case it happens to any of us, before these restrictions are lifted.
Well, typically when people develop status migrainosis, we'll often consider steroids. That would probably be my first line of therapy. So, but the problem with steroids is things like prednisone or decadron are the two common ones that are used, is that it suppresses the immune system.
Right.
So the question is during a pandemic, do you give medication for anywhere from 6 to 12 days is what the course I usually give, where they might make them more susceptible to develop the COVID-19 viral infection. So that's a discussion. I wouldn't say that I don't ever do it, but it is one that a discussion we have to have with the patients, and then you have to weigh the risk benefits between the patient and the physician.
Right.
Second thing that we do is infusion therapy. So we bring people into an infusion unit and give them intravenous medications to try to break the headache cycle. Right now, in many cases, that's not an option for many people because the staff doesn't want patients coming in for hours at a time and maybe have relatives come visit them and so forth and so on in an infusion unit for fear that either the patient may contract an infection or the staff may contract an infection. So at least in our institution, getting an infusion would be quite challenging. The third thing to do would be to give other therapies, other shots, for example, can be given either subcutaneously right underneath the things like ketorolac, which the trade name for that is Toradol. If you don't have reactions to anti-inflammatories or some other adverse reaction to the medication or an ulcer, that might be an option. There are also some other subcutaneous therapies like Imitrex can be given by shot form, and that tends to be more effective than tablets. And then there's a medication called DHE, dihydrogonamine, which can be given sub-Q or intramuscularly. So there are some things that you could do to try to break a cycle as well.
Now, things like ketorolac or Toradol, if given IM, intramuscularly, can that be done at home for those of us that might be stuck at home in this situation?
Absolutely. In fact, if you know how to give an intramuscular shot, or if you don't know, if one of your relatives or some friend, maybe that has some nursing experience, could come over and give you a shot, then that's a viable option. But the ideal would be for the patient to give the shot to themselves.
Okay, great. So also, I'm aware that steroids are often given to people with cluster. So if someone is unfortunate enough to experience a cluster attack at this time, I'm curious to know what can be done for them.
Well, the mainstay of cluster in terms to try to prevent them is a medication called verapamil, which is a blood pressure pill,
Hmm.
and a course of steroids. In fact, I would commonly give a 6-week course of steroids because oftentimes the bouts of acute cluster will last for about 2 to 3 months.
Hmm.
So giving the steroids over a 6-week time period kind of gives the verapamil a kind of a little bit of time to work for cluster headache. And cluster headaches are just so severe.
Yeah.
But the real issue, as we said before, with giving a prolonged course of prednisone to treat cluster headaches in this world where there's a pandemic, I think once again is an issue. In fact, this came up today in my office. I had a cluster patient that was whose cluster period had just begun, and in the past we had used prednisone. So we went to something called Emgality. The generic name is galcanezumab, and that's been approved for acute cluster. And so we're going to start her on that as opposed to putting her on prednisone. So there are some issues with cluster headache as well in terms of what medications you might choose in this situation.
Okay. So how do you think, I'm curious to ask this because I know you are talking to your patients online for like this. How do you think the pandemic is affecting interactions between doctors and patients?
Well, it's an interesting question. Now you have to remember that I am an older doctor, so my vantage point might be different than say one of the younger doctors in our group. But all of my visits currently are either what we call televisits, so telephone phone calls, or video visits where we do little video visits. If you have an iPhone, that in our system you have to have an iPhone to do the video visit. But I think there's probably some good and bad. I mean, from my vantage point, not being able to see the person, and at one point we did shake hands, which that may go by the wayside too. But not to have that personal interaction for me is a little bit less satisfying as a physician. The positive thing is, I think that we have a little bit more time to spend with our patients now because we're not as busy. Like I would say that I'm only seeing like maybe 40% of the visits that I used to see. So I
Mhm.
have a little bit more time to talk to the patient and kind of get to know them and discuss medical therapies as well. So I think that's the plus in this. But most of the visits are being done remotely, which is different. We can send the medications in electronically too. So really everything can be done electronically.
Mhm. How do you think it's going to change, this pandemic will change our care in the future as patients with headache disorders and with migraine?
I think this is gonna totally change the way we practice medicine. I think that now that the patients have got a taste of the televisits and the video visits, and the doctors now have got a system to actually start doing that, even starting to bill for services related to that. I think that there'll be a smorgasbord.
Mhm.
So I think what will happen is the schedulers will say, "Would you like to have an in-person visit, or would you like to have a video visit, or would you like to have a telephone visit?" And you give them a choice. So I wouldn't be surprised if the younger people who are kind of used to all the electronic media, they're going to be thinking to themselves, well, I'm doing pretty well. This is just going to be a 15-minute office visit. And why should I drive halfway across town and spend 2 hours going to see the doctor when I can just do this over the phone in 15 or 20 minutes? So I think that it's going to be convenience that'll be important for them. The other thing is some of these people who live in remote distances away from the doctors, like out in rural areas, for example, where they might need to travel hours and hours at a time, I could see how they would do a video visit. And there might even be ways in the future for us to do, limited examinations, um, through a video visit as well.
Mhm.
So I think that I think that the world is this is gonna really change medical care in the future. The real question I have is will all this video visits and televisits change the relationships you have with people? You know, will they be as strong in
Hmm.
that situation, or will the bond between the patient and the doctor be the same? I don't know.
Yeah, that is a good question. So is there anything else that you would like to add on our topic of trying to stay well during this pandemic? Because I can say I was doing really well, and I am a person who used to be horribly sick. And I usually do pretty well now. And I am missing a component of my care, and I suddenly started to not feel too good over the last couple of days. So I do think some of us are a little worried about the components of our care we're missing. So if I can speak for us, so how is there anything else you'd like to add? Speaking to those of us that are patients.
I would just say this, that I think that we're all in this together.
Yeah.
And if we all work together, and if we all understand that maybe things aren't optimal right now, but
Mhm.
there are still things that we can do, and that I think that we might need to do a little bit of an end around instead of a direct, type approach. But in the end, there are other therapies we can offer, and this pandemic's not going to last forever. I think
Right.
this is just going to be, hopefully just be a month or two where things are kind of tight, and then we can get back to our normal therapies that are so effective for many migraine and cluster patients.
Yeah. And I think the message is get creative and don't be afraid to communicate with your doctor. You may think they're gone, but call, see if they can do a telehealth visit. And don't be afraid to talk to them about some of the ideas that Dr. Martin spoke about today. So thank you so much for joining us today. And please join us again on Heads Up, the weekly podcast and webcast of the National Headache Foundation next week. Thanks, Dr. Martin, and thank you, everyone else. Bye-bye.